The next speaker is Dr. Chris Snyckers. He's going to talk on prosthetic treatment of proximal femoral fractures. Thank you, Chris.
Thank you, Mr. Chairman. Yes, I'd like to speak to you about the proximal femoral fractures, specifically looking at arthroplasty. These are my disclosures. There's no conflict of interest on this topic. So the first point is that this is a massive problem. We're going to be facing over 6 million of these fractures per year in the year 2050. And that's because of the increase of our patients, the increase of osteoporosis. And the problem is that the mortality of these cases remain high, 14 to 36%. And it's not just the mortality, the morbidity is also very high. It's estimated that to take care of a patient is 3 times more if they've been fractured than if they haven't fractured. Interestingly enough, Speed published in 1935 on complications of proximal femoral fractures, and they had about a 36% complication rate. And when Wenberg published his meta-analysis nearly 60 years later, the complication rate is really essentially unchanged. So there remain a treatment challenge. The problem as well is, if we're saying proximal femoral fractures, we're dealing with very different entities. On the one hand, we have the neck of femur fracture, an intercapsular injury, compared to the intertrochanteric fracture, and all of these are grouped together as hip fractures. Biologically, this area is very unique. We have a watershed area of blood supply. There's retrograde blood supply into the capsule, combined with an area of very good blood supply in the trochanteric area, and then again a watershed area to the shaft. And biomechanically, this area is really, really challenging. 4 to 7 times of the body weight goes through the hip during weight bearing, and even non-weight bearing movements like a straight leg raise, you have up to 3 times the body weight. Just moving your patient on the bed onto the bedpan and down, you get 4 times body weight going through the hip. Torsional forces, because of the muscle strains around the hip, create massive torque forces around. So whatever we're doing in the hip, we have to do it. It has to be stable and it has to last. So if we look at neck of femur fractures, or the classic intercapsular fractures, first, what would be nice is let's have a classification, tells us what to do. Numerous classifications have been tried, all of them. This is the Garden, it's probably one of the best known, but all of them have been shown to be extremely poor in inter-observer reliabilities. So another thing we try to do is to look at function and say, well, let's try and get functional scores, and maybe that will show us what to do. Again, we only end up with these blunt things, comparing community walkers, domestic walkers, and nothing much more better than that. And the only really thing that's been shown to be effective is to say whether it's displaced or undisplaced. So if we go look at what's being done worldwide, one can see with a displaced intercapsular fracture, it's very clear that the arthroplasty has been established and does very well. If you look at the survival curve of the displaced intercapsular fracture versus the arthroplasty on the left. One can even see in countries like Norway, prone to internal fixation, over the years you can see the increase of arthroplasty. So it's become quite accepted to use arthroplasty for displaced femoral neck or femur fractures. But what about the undisplaced? So if you look at the survival curves for an undisplaced neck or femur fracture, you compare it to the displaced neck or femur fracture, and specifically to the arthroplasty. Begs the question, should we be doing internal fixation for these fractures at all? Let's just look at what the literature says. There has been 19 trials with over 3,000 patients. The problem with these trials, they all got selection basis. They're poor trials. But it does show, of course, that the internal fixation, less blood supply, a quicker procedure, but massive complications, 40% compared to 11% in arthroplasty. And interestingly enough, there's no difference when it comes to hospital stay, morbidity, and mortality of the arthroplasties. So if we're doing arthroplasty, of course, we've got a couple of choices. We can do a total hip, we can do a hemi. In the hemi group, we can do a bipolar, we can do a unipolar. And then there's the question, should we be cementing or not? Again, let's go see what the literature says. Vast amounts of studies comparing total hips, bipolars, unipolars. Again, they're unclear, they don't help us. So maybe we should look at the registry, see what the rest of the world's doing. If you look in Norway, you can see that the bipolar versus the unipolar in those red circles, the use of bipolars are very, very popular and increasing. Unipolars practically not being used, total hip also not that much. But in Sweden, it looks different. Unipolars, very, very commonly used. They're in the blue line. The total hips in green, also quite popular, and the bipolars are becoming less and less popular. And this is quite interesting because if the Swedish register shows that the unipolar prosthesis does poorly, is associated with pain and erosions and a high risk for reoperations. But still they use them. But what does the literature tell us? Well, there's 19 trials with over 2,000 patients comparing bipolars to unis. There's no difference. There's no difference between a bipolar and a uni. But when you start looking at a hemiarthroplasty for total hip versus total hip in the treatment of in the treatment of intercapsular fractures, or neck or femur fractures, the total hip has better function, lower revision rates, but a longer surgical time. So it says that maybe we should be doing total hips. And if we're doing total hips, what type of bearing surface should we be putting in? Now, Wingstrad and Skalka started publishing on these dual mobility or tri-mobility prostheses, and they seem to be doing very, very well. And one can see, for instance, in the few registries that look at these, this is the Swedish registry, you can see the increase in the use of dual mobility prostheses over the last couple of years. So should we be cementing them? Well, again, let's look at the registries. You can see that in England, more than 70% of the stems are being cemented. Sweden, of course, 97% being cemented. Norway, most of these are just neck or femur fracture statistics, all cemented stems. And why is this? Again, if we look at the studies, one can see cemented implants in the treatment of neck or femur fractures have less pain, less morbidity, less mortality. And if we start, the big concern, of course, is these cement syndromes, or cement implantation syndromes. And comparing this in the literature and all the trials that are available, there's no significant difference in intrasurgical complications between cemented and uncemented stems in neck or femur fractures. Surgical approach, well, it seems to be very clear if you look at the registries, most people are doing this through a lateral approach. So in conclusion, unfortunately I can't tell you what to do. We still don't know. This new study, the health study, is out trying to ascertain what is it that we should be doing. And we're hoping that once these results start being published, that we can really for the first time say what we should be doing. But what I can say is you won't be wrong, and in fact you might be right. If you see a neck or femur fracture, a displaced neck or femur fracture, and maybe all of them, to treat that with arthroplasty, to be doing a cemented stem, to do a total hip, probably a double mobility type prosthesis through a lateral approach. The other fracture pattern, of course, is the intertrochanteric fracture. Now, this is a completely different animal. Now, the intertrochanteric fracture makes up 45% of proximal femoral fractures. And of these intertrochanteric fractures, nearly 40% of them are these very unstable 3 or 4 part fractures. Now, we do know that internal fixation can treat up to 80% of intertrochanteric fractures. But the problem is that there's still a 3 to 16% overall failure rate of internal fixation. And when you get to the unstable intertrochanteric fracture, those complication rates start going up, especially in the elderly, and especially in the osteoporotic fracture or the osteoporotic patient. The interesting thing is that arthroplasty has been used very successfully over the years to treat failed internal fixation. Why? Because there's immediate weight bearing. You don't have to wait for union. The question then obviously starts to be begged to be asked, shouldn't we then just be putting these arthroplasties in for intertrochanteric fractures de novo? Why wait for the internal fixation to fail, especially in these unstable fracture patterns? The cat was really thrown amongst the pigeons in the 1970s when Tronzo published on these publication on bipolars, the use of bipolars in intertrochanteric fracture showing good results, less morbidity, and excellent outcomes. This was followed by Henke's first publication in the late 80s, again in the late 90s, showing very good results with bipolars, and in fact, fewer complications and fewer morbidities, or better mobility in his patients. Singh published in 2010, consecutive group of patients of nearly 70 patients over 70 years, where he didn't use a bipolar, but used a total hip replacement. Again, fewer complications, better mobility. Harris hip scores averaging 76 at 3 years for these fractures. And these were all very unstable 3-4 part fractures in osteoporotic patients. But what does the literature say? So if you remove yourself from the case studies, there are unfortunately only 2 randomized control studies out there comparing the use of arthroplasty in the intertrochanteric fracture. The one by Kim and the other one by Steppets. It's a smallish cohort of about 148 patients, and it shows no significant difference. No difference in surgical time, no difference in mortality, and more importantly, no difference in loss of mobility. But the arthroplasty group has an increased transfusion rate and therefore an increased inferred complication rate. So the question is, should we be doing this at all? At least what this probably shows us is that if done correctly, an arthroplasty is not worse than an internal fixation, but certainly shouldn't be seen as the gold standard. So if we look at this case, for instance, this is a 70-year-old female. She slipped and fell. She's presenting with pre-existing osteoarthritis of the left hip, the ipsilateral hip of the fracture. But she's also got a revision hip on the right side that's causing pain. This is going to be a mobility problem afterwards if you're doing internal fixation. Furthermore, she's got subtrochanteric extension of a fracture pattern. So this is the type of patient where you really should start saying, can I treat this with internal fixation? And it might be that it's going to be very difficult. So here we decided to treat with the uncemented taper-fluted stem, modular body and neck, 36 millimeter polybearing, uncemented cup and a trochanteric claw with good results. This case is a 90-year-old or 89-year-old female, mild OA, but she falls a lot. She's already had a previous pelvic fracture that stabilized through union. But she presents with this very comminuted 4-part intertrochanteric fracture with medial calcar comminution. We know this is difficult to treat with internal fixation. High failure rate. So maybe in this case, when you're doing surgery, you already have a de facto trochanteric osteotomy. You just push the abductors out the way. You can take the multiple fragments out. And you can stabilize this, in this case, with a proximal femoral replacement, cemented stem, porous metal collar, 36 millimeter metal and polyarticulation, an uncemented scup with some screw augmentations, and a trochanteric cable claw, again with good outcome. So I think in conclusion we can say the proximal femoral fracture is a varied group. We really don't know exactly what to do with them because they're so poorly classified. But if we go and look at all the literature available, we can definitely say that the displaced intercapsular fracture, so the neck of femur fracture displaced, and who knows, maybe all of them should be treated with arthroplasty. If you're doing an arthroplasty, the registry suggests you should be doing a total hip, cemented, via a lateral approach, and possibly looking at a double mobility bearing. The intertrochanteric fractures, there's no clear advantage, so it's a case-to-case base. Thank you.
We have about 2 questions from the floor, maybe. Any questions for Chris? Maybe more of a comment, really, because, I mean, you elaborate on that, Chris. I looked at your results between cemented and uncemented prosthesis, and you refer to the UK and the Swedish registers. What it really tells us what is happening. It doesn't tell you what the results are.
No, that's the point.
I think that's a very important point to notice. You can't say cemented or uncemented is better than the other one. It just tells you what is used in that country. Yeah. Although when you show the Australian one, it shows a difference in the neck of femur fractures.
Yeah, I think the reason I use these registries is that not all the registries look at the fracture neck of femur group as a group on their own. What you're trying to see is what are the people doing based on their experiences in their countries and also what their publications are showing. The publications are there, they're poorly powered, but they are there to support what's being done in the registries. But one can see, for instance, with bipolars, unipolars, that there's still quite a variance, and it is just a show of hands really as to what they are doing there. Yeah.
I think you showed as well in your intertrochanteric fractures some that are cemented in. Do you think that's wise in these comminuted intertrochanteric type fractures with cement intrusion?
I wouldn't. I try and use the uncemented prostheses because they've done very well in the treatment of failed internal fixation. So they've been shown to do quite well. The concern, of course, is the union of your fracture. The point is that if you look at the initial studies that were published, these bipolars and Henkies and all these, they all used cemented implants. So those original publications that did so well were all with cemented implants. Now, whether we should be looking at that, I don't think that the union is probably the thing. It is more getting the patient up and mobile.